Okay, thank you for joining today, ladies and gentlemen. Today we have Dr. Sherif Naguib joining us from Cairo, Egypt. Dr. Sherif will be talking about breast conserving surgery in multicentric and multifocal breast cancer. Thank you for joining us, Dr. Sherif, and the floor is yours.
Thank you, Dr. Hisham, for inviting me over for this presentation. I would like to present today the possibility of breast conserving surgery for multiple ipsilateral breast cancer. This is the name they gave to multifocal and multicentric breast cancer. And I have to tell you that this issue is one of the most debatable and one of the most controversial issues in breast cancer surgery today. My name is Sherif Naguib, and I'm a professor of surgery at the National Cancer Institute of Cairo University. Now, to start, let's try and see what is the definition of multilateral multiple ipsilateral breast cancer. I have a problem with moving. Okay. Now, multiple ipsilateral breast cancer is defined as multifocal or multicentric disease. Multifocal disease is two or more breast tumors found in the same quadrant, and the distance between them shouldn't exceed 2 centimeters. And in some studies, they went up to 4 or even 5 centimeters. They would still call them multifocal if the distance is so big. But in multicentric breast cancer, the tumors are found in two different quadrants, and the distance between them is exceeding 4 or even 5 centimeters. So it's mainly tumors that are close together in one quadrant are called multifocal. Tumors that are far from each other or widespread all over different quadrants are called multicentric disease. It was found that multifocal breast cancer are very similar histologically and have the same molecular characterization, while multicentric tumors are different histologically sometimes or most of the time, and their molecular biology also differs. So maybe it would be easier in the near future to differentiate between multifocal and multicentric disease through molecular characterization. Now, is the multifocal and multicentric disease common? Yes, we see it very commonly nowadays. Actually, in the 70s, as far as the 70s, serial sectioning of mastectomy specimens showed multicentric and multifocal disease in up to 60% of breast cancer patients. And at that time, no MRI was used. It was not even invented. But nowadays, in 2018, a study found it was a multi-study, and it found that multiple ipsilateral breast cancer were found in up to 25%. Nowadays, identification of multifocal multicentric disease is much easier because of the great advances of radiodiagnosis that we are using, like ultrasound, contrast-enhanced mammography, and MRI. Nevertheless, many of the cases are still missed nowadays, and this is why adjuvant radiotherapy is an important necessity for treatment, aiming at local control after breast conservation to make sure that if multiple ipsilateral breast cancer is present, it would still be treated. Now, it was found that multifocal and multicentric breast cancer had a worse prognosis than unifocal breast cancer. It was found that they had a higher number of axillary lymph node metastasis, and a higher number of estrogen receptor negative cases and high proliferative activity. And strangely enough, they also found that whatever the type of surgery used for multifocal, multicentric breast cancer, the locoregional and distant relapse were the same. As you will see in this study in 2015 by Neri et al., on the first graph shows breast cancer-specific survival in patients who were submitted to breast conservation, and the upper curve is related to unifocal breast cancer, while the lower curve of multifocal breast cancers shows, of course, worse breast cancer-specific survival. On the right chart, or on the right graph, you will see that the best breast cancer-specific survival was related to unifocal cancers, the highest curve. The curve in the middle is related to multifocal breast cancer, which is a lower survival. And the worst survival was found with multicentric breast cancer. Nevertheless, if you compare breast cancer, breast conservation surgery to mastectomy, you will find that the survival was almost the same when you compare each unifocal, multifocal, or multicentric alone. They gave the same survival, whichever the surgery used was. So for many years, mastectomy remained the standard treatment for multifocal and multicentric breast cancer, and that was due to the finding of higher risk of locoregional recurrence with multifocality and multicentricity, and of course, a less good cosmetic outcome with this kind of tumors, multifocal and multicentric, because of larger excisions. So the surgical treatment remained as mastectomy. Nevertheless, many authors started thinking of breast cancer, breast conserving surgery for this kind of disease. Actually, breast conserving surgery has been found to be as good as mastectomy and to give equal survival outcome as mastectomy for unifocal breast cancer. Nevertheless, the early studies that tried breast conserving surgery on multifocal and multicentric breast cancer reported a higher rate of locoregional recurrence, which reached up to 40% higher when compared to mastectomy. So the earlier studies did not really encourage the surgeons to use breast conservation for multifocal and multicentric breast cancer because of higher rate of recurrence, and mastectomy remained the standard treatment. Nevertheless, a closer look at these studies found that these studies lacked adequate patient number. They also lacked the use of routine screening mammography and advanced radiodiagnostic tools. Also, these studies lacked the use of targeted therapies and the standard chemotherapy that we use nowadays. The radiotherapy techniques were not as precise as today, and the analysis of surgical margins in these studies was not really very accurate. So accordingly, this encouraged some surgeons to start advocating breast conservation to multifocal and multicentric disease. Now, it all started by the finding in the 70s. As you see, this publication was in 1977, who found occult multicentric foci of carcinoma after serial sectioning of mastectomy specimens in up to 20% of the specimens, of mastectomy specimens that they dissected. So meaning that multicentricity was found and was known since the 70s. And in the NSABP B6 study, which was almost 10 years later than the finding of this high rate of multicentricity in breast cancer patients, when it compared breast conservation, or what they called at that time segmental mastectomy, when they compared it to total mastectomy, they found that the segmental and the total mastectomy were similar as regards disease-free and distant disease-free and overall survival at 5 years. So this encouraged surgeons to start trying breast conservation, or segmental mastectomy as it is called here, for the treatment of multifocal or multicentric breast cancer cases. It all started with the turning point that was this publication in 1999 by the Institut Curie group that included, of course, Krishna Kloof, who found that breast conservation, when compared to mastectomy, gave the same 5-year overall survival, or let's say similar 5-year overall survival, 94% when compared to 90% in mastectomy, and the 5-year ipsilateral breast cancer recurrence was 11% and a little bit less with mastectomy group. So this encouraged surgeons to start using breast conservation, and this is a group of studies, almost 6 or 7, that were encouraged to compare breast conservation to mastectomy in patients having multifocal and multicentric breast cancer. And as you can see in all these studies, they found no significant difference in the recurrence rates or in the survival rates when they compared mastectomy and breast conservation for multifocal, multicentric breast cancer. So what are the choices that we have today to treat multifocal, multicentric breast cancer? It's either total mastectomy, meaning the removal of the whole of the cake, or partial mastectomy, which means removal of one wedge of the cake that contains the multiple tumors, or do multiple lumpectomies, meaning removal of the tumor with safety margin in separate excisions. And of course, the last two, whether partial mastectomy, where you remove the segment as a whole, or multiple lumpectomies, where you remove the different tumors separately, each in a separate excision, you probably need reconstruction to improve the cosmetic result. This encouraged even the St. Gallen Consensus Conference of 2017 to endorse breast conservation for both multifocal and multicentric disease and they put at that time 3 conditions in the St. Gallen. They required free surgical margins. They required radiotherapy to be given in all cases, and they required the satisfactory cosmetic result at the end. The first trial that evaluated breast conservation in women with 2 or 3 tumors was the American College of Surgeons Z11102 that lasted between 2012 and 2016. It included 198 eligible female patients that were all aged over 40 years, that were all BRCA negative, that did not receive neoadjuvant systemic therapy, and that had never had previous radiation before. And they all had unilateral breast cancer that consisted of 2 to 3 lesions, not less than 2 lesions, not more than 3 lesions. their sizes did not exceed 5 centimeters, and there was at least 2 centimeters between the lesions, meaning that they were multicentric in most of the cases, and the lymph nodes could be positive in these patients. These multicentric diseases, the multicentric breast cancer tumors, were excised through either single or multiple incisions. They accepted no income tumor as an acceptable negative margin. Oncoplastic reconstruction was allowed, and adjuvant systemic therapy was given as normal. Radiotherapy also was given as normal, and each tumor bed, if the tumors were resected separately, in separate incisions and separate excisions, each tumor bed was given a boost of radiation of 10 to 16 grays on condition that no more than 40% of the breast tissue would receive more than 60 grays. Otherwise, the dose of radiation given to the breast could be excessive and could lead to burn of the breast. Now, the American College of Surgeons Z11102 trial actually looked at two endpoints. The primary endpoint was the risk of conversion to mastectomy and the number of operations required to achieve negative margins with breast conserving surgery, because the excessive number of operations might lead at the end to conversion to mastectomy if you cannot achieve negative margins, and this will definitely be detrimental to the patient. Secondary endpoints were the cosmetic appearance and local recurrence rates. So the number of operations required to obtain negative margins was found to be a single operation in almost 3/4 of the patients. In 3/4 of the patients, they could achieve negative margins with only from the first surgery, from the first shot. Then almost 23% of the patients required two operations to achieve negative margins, and the rest of the patients required maybe 3 or 4, which were very less. As you can see, the percentages did not exceed 1% or 2%. Now, the amount of patients who required mastectomy to reach negative margins did not exceed 7%, while in 93% of the patients, negative margins could be achieved with only breast conserving surgery. So the primary endpoints were really encouraging for breast conservation in the treatment of multifocal, multicentric breast cancer. Now, these figures that were found with the study were actually comparable to other studies where other studies concerned with mastectomy. As you can see, 14% of patients required re-excision in the study, and mastectomy and conversion to mastectomy did not exceed 4% in this study by Monica Moreau. And in another study, the breast excision for once to reach negative margins was successful in 50% of the patients, and women required mastectomy in almost 10% of the cases. So the findings of the American College of Surgeons Z11102 study were very encouraging. Now, when they evaluated the secondary endpoints, which are the local regional recurrence and the cosmetic appearance at the end, they found that good or excellent cosmesis could be achieved in 70 or more % of the patients. And there was no significant difference in cosmetic appearance when the patient had 2, 3, or more lesions. So the number of lesions did not differ, the number of incisions did not differ, and the number of lumpectomies did not differ in the final cosmetic result. They also required to evaluate the locoregional recurrence in these patients, and they found that the 5-year cumulative incidence of locoregional recurrence was 3%. 5-year rate of recurrence in patients who did not have MRI was 22.6% compared to 1.7% in patients who had preoperative MRI. And this shows how important MRI is in the diagnosis, in the preoperative diagnosis of patients with multifocal or multicentric disease. A very important study is this one, which evaluated breast conservation in multiple ipsilateral breast cancer. And this study is a multicentric study, and it evaluated papers that were published between 1988 and 2015 that compared breast conservation and mastectomy for multiple ipsilateral breast cancer. It included 24 retrospective studies that had more than 3,500 patients who all had multiple ipsilateral breast cancer and who underwent breast conserving surgery. And at the end, it came out with the conclusion that until today, and this is really unfortunate, but until today, the available studies that they had a look at were mainly of moderate quality, historical, underpowered, and they were all associated with limited follow-up, and they were biased. And accordingly, they concluded that the evidence was inconclusive and they couldn't reach a verdict and they couldn't reach a decision whether breast conservation can be added to the guidelines in treating multifocal or multicentric breast cancer. So as I told you at the beginning, this issue is one of the most controversial and one of the most debatable issues nowadays in breast cancer treatment. Of course, I'm sorry, they concluded at the end that a future randomized trial is required because until today there hasn't been one single randomized control trial comparing breast conservation to mastectomy for the treatment of these cases. This encouraged the Miami trial, which is a trial that was started in the UK and which included 25 breast units, and it was planned to extend from June 2018 to December 2021. And at the beginning, it included more than 1,600 patients. But then they were so thorough in including their patients and excluding those who did not fit with the inclusion criteria that the number of randomized patients dropped down from 1,600 patients or more included at the beginning. But then after exclusion of so many patients, they could only randomize 4 patients. And of course, this trial could not be evaluated and the trial failed and stopped. So this is to show you how difficult it is to plan a controlled and randomized trial to evaluate breast conservation against mastectomy for the treatment of multiple ipsilateral breast cancer. A very interesting aspect of breast cancer surgery that is very closely related to our the topic that we are discussing today is the lobar surgery. Lobar surgery started by the sick lobe hypothesis. Now, we know that very long ago, in the year 1840, Sir Astley Cooper presented the anatomy of breast as being formed of duct globular units that were radially situated in the breast and that opened in 15 to 20 openings of major ducts on the nipple. So these lobar units that amount to 15 to 20 lobes are the base of the anatomy of the breast. And this encouraged some anatomists to and some genetic specialists to produce their theory that breast cancer was initiated during embryonic development, and it involved the entire lobe that Sir Astley Cooper so well described in the breast. So breast cancer can affect the whole lobe, and this is why multifocal disease is usually a disease that affects one lobe, and this is why it is called the sick lobe hypothesis, and it suggests that multifocal breast cancer is fundamentally a genetic mutation that affects one whole lobe, while multicentric disease is explained by synchronous malignant transformation during embryonic development, and this malignant transformation can occur in two or more sick lobes. So this sick lobe hypothesis led to lobar surgery introduction for multiple ipsilateral breast cancer. As you can see in the figure that we show you here, excision of two elliptical segments in the presence of multicentric disease. And these elliptical segments could be connected by a retroareolar bridge, could lead to adequate excision of multicentric breast cancer. You don't have to remove the whole breast, but you can remove two elliptical segments involving the different tumors, and these would be connected by a retroareolar bridge. And such approach is termed a multi-segment tissue resection, and the resulting defect that results after excision is so easily closed without the need for complicated oncoplastic procedures. So this could be tried for the treatment of multicentric disease and breast conservation. Now, I will give you a rapid summary of the chronological advances that led to breast conservation for multifocal multicentric disease. In the 1970s, it was found that multicentricity and multifocality was a part of mastectomy specimens in up to 60% of the time. In the 80s, they found that locoregional recurrence and survival were the same for unifocal disease when they compared breast conservation to mastectomy. But the earlier studies that compared breast conservation to mastectomy for multiple ipsilateral breast cancer found acceptably high locoregional recurrence with breast conservation, but these earlier studies had many defects. So in the 2000s, more recent studies with larger cohorts demonstrated reasonable local control for breast conservation in the treatment of multiple ipsilateral breast cancer. And in this, that led the St. Gallen's guidelines in 2017 to endorse the use of breast conservation for multifocal and multicentric breast cancer. And recently in the 2019-2020, contemporary data were analyzed to approve the use of breast conservation for multifocal multicentric breast cancer. Nevertheless, until today, breast conservation is still not in the guidelines for the treatment of multifocal multicentric breast cancer. Now, an interesting aspect is the sick lobe hypothesis and the lobar surgery for multicentric breast cancer, which appeared with lobular anatomy of the breast that was presented by Sir Astley Cooper in 1840, and which led to the sick lobe hypothesis in the late 90s and the beginning of the 2000s. And in 2022, lobar surgery was introduced as a new concept for optimal resection of multiple ipsilateral breast cancer. At the end, we conclude that multiple lumpectomies for multiple ipsilateral breast cancer is a promising therapeutic option. Nevertheless, it is not in the guidelines yet. Prospective randomized controlled trials are required, and they should include adequate number of patients to validate this treatment modality, taking into consideration that, of course, oncologic safety is a first priority. Radiotherapy boost to each and every single tumor bed is mandatory, and this will be controlled by tissue tolerability to radiation. And the final result should include acceptable locoregional recurrence and satisfactory cosmetic appearance. And I thank you very much for your attention.
Thank you, Dr. Sherif, for this excellent talk. We start by taking questions from the audience. Please, if you have a question, raise your hand. I have a question myself. So if you do this, if you're going to do multiple lumpectomies in a multicentric disease, do you do it from separate incisions, or do you still have to do it from one incision?
Actually, we have to admit, number one, that it is not still in the guidelines. So you are not really very safe to do it unless the patient is included in a trial. You have to do it under control. Nevertheless, because it has been shown to be promising, you can do it if the tumors are close to each other. You can do it through one single incision. But if the tumors are separate and at a long distance between them, you can use separate incisions. Nevertheless, two very important precautions are required. Number one, you have to include, you have to mark the tumor bed with clips. Each single tumor bed has to be marked by clips because each tumor bed will have to receive boost radiation when required in young patients. And the addition of the addition of all the dose of radiation that is given to these separate tumor beds should not exceed 60 grays in less than 40% of the breast volume.
Okay, we have a question from the audience. So how many tumors can we excise? Is it just 3 or maybe more?
Actually, they tried up to 3 in the American College of Surgeons Z1111-02. They tried even more, but it all depends on the look on the final cosmetic appearance that you will have. Of course, in large breasts, you can remove, you can use single excisions to, or separate incisions to multiple tumors, and then you can do a therapeutic mammoplasty to improve the cosmetic result. But in small breasts, it will be a problem. So I think in small breasts, mastectomy is definitely much easier, safer, and will give you a better cosmetic result.
Okay,
So
Dr.
it all
مدحت
depends on the
خفاجة.
size of the breast.
دكتور مدحت خفاجة.
ايوه ثانك يو دكتور شريف ريالي انت بتثبت ان مغني الحي يطرب.
دكتور مدحت، انا سعيد بوجود حضرتك، وده شرف كبير.
هو اصل جدع هشام ده انا كنت مختلف وياه انه بيجيب ناس اجانب دايما وما بيجيبكوش يعني.
ايوه فندم.
جابك انت وعمر زكريا المره اللي فاتت. المهم، الحقيقه الاستادي بتاع مالتيبل تيومرز في البريست دي كان عملها واحد اسمه جالاجر في السيفنتيز في ام دي اندرسون، بسيريال سيكشن على ماستكتو سبيسمنز، ولقى 70% في مالتيبل تيومر.
مظبوط يا فندم.
لذلك قالوا لما جه البريست كونزرفنج سيرجري دي، انا عايز اوضحها يعني، فقالوا المين تريتمنت في البريست كونزرفنج سيرجري از راديو ثيرابي، از نوت سيرجري، لانه بيتيك كير اوف ذيس مايكروسكوبيك ديزيز. والحكايه دي اتعملت في السبونتينيوس ميموري كارسينوما في الرئه في المايس، ووجدوا ان ال 1800 سنتيجري is enough to sterilize the breast في these mice يعني spontaneous memory carcinoma. لذلك هو التريتمنت mainly it is radiotherapy or it's not surgery. دي واحدة. تاني واحدة معرفش، انت قلت ان in distant metastasis في المالتيفوكال ولا مالتي سنتريك it is the same like unifocal. يعني ايه الاكسبلانيشن ده؟ انا اللي فهمته من البرزنتيشن، ال ال ما يبقى
لا
فيه مالتيبل تيومرز
لا لا
المتوقع ان الديستانت ميتاستس تبقى اديتيف، يعني الضعف السنجل او 3 اضعاف لو 3 تيومر.
ايوه.
انا اللي فهمته من كلامك انها اذا سيم، صح ولا انا غلطان؟
لا لا يا فندم، اللي انا حاولت
Is
ابين.
it additive؟
اه ات از اديتيف،
لو
كلام حضرتك مظبوط. هم وجدوا ان البروجنوسيس اوف مالتي سنتريك ديزيز از ذا worst when
يس يس،
compared to multi
بس
focal.
انا بقول ديستانت ميتاستس
وانكلودينج الديستنت ريكارنس، الديستنت
بيبقى اكتر
ميتاستس او
يعني
الديستنت
اديتيف.
ريكارنس يعني، واللوكو ريجنال ريكارنس الاثنين.
أي لا، سيبك من لوكال ريكارد.
والديستنت
الديستانت
والديستنت ميتاستس برضو لا it was worse.
اديتيف يعني مثلا
it is additive
التو
يا بيه، انا هقول
تيومرز.
لحضرتك. ده هم دلوقتي عايزين يراجعوا التي ان ام كلاسيفيكيشن. they want to revise the TNM classification, and the actual TNM, when you have multifocal or multicentric disease, gives the a T stage that is related to the largest tumor. So if you have many tumors,
لا
largest
اندرستاند.
is 3 centimeters, then it is a T2. They do not add separate sizes together and take the sum of it.
اوكي.
But
دلوقتي انا
when they
السؤال بتاعي
compare.
مش ده،
ما
السؤال
انا هقول
بتاعي
لحضرتك.
هل
لا لا،
الديستانت ميتاستاسيس
with this metastasis is worse with
ماشي ماشي
multicentric. انا
ماشي،
قلت.
بس هل هي اديتيف؟ يعني قصدي ايه؟ يعني لو الديستانت ميتاستاسيس بتحصل في 10% من السنجل، التو تيومرز يعملوا 20%، هل ده ترو؟
this is what they found, and accordingly they want to
ضعف يعني
TNM
بحسب
classification.
اديتيف.
additive يا بيه، additive.
اصلا ما هو انا يعني انا عملت بيبر واتنشرت في الكانسر على البروجنوزس ده في السبعينات، البروجنوزس اوف ذا سكند بريست كانسر الكونترالاترال، لان كانت ساعتها بنعمل ماستكتومي.
ايوه
جمعت الحالات بتاع الميموريال على 20 سنه،
ايوه
لا في العيانين، وخدت
ايوه
منهم الكارسينوما اوف ذا اذر بريست.
ايوه
لقيت البروجنوزس ما بيفرقش. انا كنت متصور ان الاميونيتي في السكند بريست كانسر هيخلي البروجنوزس احسن،
ايوه
فطلع ان الكلام ده مش مظبوط. فطلع ان الايه الاثنين ذا سيم حسب الستيج يعني.
ايوه
ده سؤال. الحاجه الثانيه، انت كل اللي انت قلته 5 year survival،
ايوه
و 5 year survival is not
not
enough.
enough.
لازم 10 year survival، صح؟
بالظبط بالظبط بالظبط. ما انا عشان
فهو
قلت
دي
لك
كلها انا رأيي ان لازال
الستاديز مش كافيه.
يعني لازال العملية عايزة
اه 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 اولا
شغل
النمبر اوف بيشنتس
انترناشونال.
قليل.
لا يعني ما دام الحالات قليله والناشونال مش نافعه، زي ما انت قلت ان هم
أيوة.
في انجلترا جابوا 70 يونت بريست يونتس ولا حاجه زي كده،
25.
25
اه
وما نفعتش.
لا
يبقى عايزه انترناشونال ستادي،
بالظبط
كذا بلد تشترك فيه
بالظبط.
عشان تحل
هم
المشكله دي،
ابتدوا
لان المشكله دي
ابتدوا
مش
ب
هتتحل.
1600 عيانه، صفصفوا على 4.
ايوه، ما هم كانوا ستريكت في كرايتيريا، في الانكلوجن كرايتيريا لغايه ايه، توايدن شويه يعني،
ايوه
توسعها
ايوه
شويه،
ايوه
وتشتغل انترناشونال في مالتيبل كانسر سنتر اول اوفر ذا وورلد اف بوسيبل يعني.
بالظبط يا بيه.
آه.
اللي عايز اضيفه كرد لسؤال حضرتك، ان هم لما قارنوا الليمف نود انفولفمنت بتاع المالتي سنتريك مقارنه باليوني سنتريك، او ال
آه.
او ال او مقارنه باليوني فوكال، لقوا ان الليمف نود انفولفمنت بتاع المالتي سنتريك اعلى.
ايوه بس اعلى يا شباب،
فهم
اعلى
اعلى
بالنسبه
ليه؟ اعلى
للعدد
ليه؟ لان التي ان ام كلاسيفيكيشن.
ولا نسبه اقل؟
انا بتكلم على ستيج تو ستيج، يعني لما قارنوا
اه.
نفس الستيج. ف
مم.
ف ف فهم ابتدوا يحسوا ان التي ان ام كلاسيفيكيشن اللي احنا ماشيين عليه دلوقتي مش مظبوط، لان احنا
ماشي.
النهارده بناخد التي ستيجنج according to the largest size of tumor
لا لا،
present.
من غير ان يتحسب انه تو بيشنتس
فهم ده هم عايزين دلوقتي بقى
او
يضيفوا.
سبيشال كاتيجوري، سبيشال كاتيجوري
اه
حد لوحدها.
they want to add the sum of the different sizes of the different tumors. ولما عملوا كده لقوا ان الليمف نود percentage is the same بقى ساعتها ما بين اليوني فوكال والمالتي فوكال، او اليوني
طب ما ده
فوكال والمالتي
غريب،
سنتريك.
طب ما ده غريبة يعني.
اه ما
طيب
هم عايزين يغيروا التي ان ام ستيجنج.
طيب الحاجة التانية اللوبر سيرجري،
ايوه
لو الحكاية دي مظبوطة
ايوه
يبقى اللوبر سيرجري لازم تتعمل برضك في السنجل تيومرز. ليه انت عايز تكسكلود السنجل تيومرز من اللوبر سيرجري اذا كان ده صحيح يعني؟ فدي عايزة راندومايز ترايل برضك، تعمل
هي
لوبر سيرجري في السنجل تيومرز واللي بنعمله دلوقتي ونكمبير.
دي نقطة مهمة. This is an interesting theory that I thought I would
لا
present
يعني ما
to the
دي
audience.
المسابقه عايزه راندومايز ترايل. انا
طبعا
رايي انها تتعمل في السنجل تيومر.
ايوه.
صح.
هي الحقيقة حاجة في النص ما بين ماستكتومي و مالتيبل لامبكتوميز، يعني هي
لا يعني
بتعمل.
ما دام انت خدت الثيوري اللوبر سيرجري دي،
ايوه
يبقى برضك ممكن نطبقها على السنجل تيومرز، واي نوت؟
كلام حضرتك مظبوط، لان هي ده
فيبقى
genetic mutation.
نعمل راندومايز ترايل على السنجل تيومرز الاول عشان تبقى سهله،
ايوه ويتشاف
وبعدين
اللوكال ريكارنس.
وبعدين نبقى نعملها على المالتيبل تيوب،
اه
لكن
ويتشاف
مش
هل اللوكال
العكس.
ريكارنس احسن مع اللوبر سيرجري.
يعني هي تتعمل لوبر سيرجي في سنجل تيومر راندومايز ترايل،
بس زي
واحده
ما
يتعمل
حضرتك قلت
لوبر
عايزه 10
سيرجي.
years، عايزه 10 year فولو اب.
اي ماشي، بس المهم ان ايه، تبتدي تعملها يعني.
ايوه ايوه
حضرتك قصدك ايه بلوبر سيرجري؟
ما هو اللي قالها انك
اللي
تشيل
احنا قلناها
الضغط
في اخر
لحد
سلايد.
النبل. لا
لو
يا علوم، اكسلنت برزنتيشن الحقيقه، ممتازه.
اشكرك يا دكتور
keep the
مدحت،
better.
اشكرك يا بيه، اشكرك يا بيه. انا
طيب
هوري بس الدكتور هشام اللوبر سيرجري كنا بنتكلم عليها، اللي هي دي،
اوكي.
اللي هي resection of different lobes with a bridge of retroareolar tissue relating both segments removed. ودي بيعملوها في المالتي سنتريك. It's only a new theory that is suggested يعني
اوكي. في سؤال
كأوبشن في الماستكتومي.
المالتي سنتريك ايه احسن ايمجنج يتعمل له؟
المالتي سنتريك definitely الام ار اي، definitely
اوكي.
MRI. يعني one of the indications of breast MRI is the presence of more than one tumor. على طول لازم تطلب MRI لسبب ان لو انت عندك 2 تيومرز، ايش ضمنك ان مفيش واحد ثالث او رابع او خامس صغير ومش باين في الماموجرافي؟ فMRI على طول.
اوكي.
بس
دكتور
انا
ابراهيم
اقدر
سلام.
اقول لك يا شريف،
ايوه يا
في
فندم،
مشكله في الام ار اي هنا، ما اعرفش كنت لاحظتها اللي ولا.
ايوه يا فندم.
الام ار اي ده لازم يتعمل بالجادولينيوم.
ايوه
هم ما بيعملوش بالجادولينيوم عشان نبقى واضحين. ليه؟ لان الحقنه ب 1500 جنيه.
اه
اللي لما قلت الجادولينيوم، انا ما بكون في مستشفى الموريال في الاوبريتنج روم واشوف الام ار اي على بعد 4 متر، شايف الليجنز كويس جدا
ايوه
بالام ار اي.
ايوه
هنا بتاع زباله ما يدخششها. فلما سالت اكرام حامد قلت
ايوه
له انتوا بتعملوا لنا الام ار اي من غير جادولينيوم وده
ايوه
ما ينفعش. قال لي
ايوه
لا، لو انت عايز جادولينيوم هتدفع 5000 جنيه، ولازم تكتب كده
اه
انك
اه
عايزها بالجادولينيوم
اه
عشان تبقى عارف يعني انهم
اه
بيخمونا يعني.
اه
لان انا بلاحظ الام ار اي في مصر دي زباله
ايوه ايوه
صراحه كده، عشان ما نلفش وندور يعني.
ايوه
طيب
اتمنى.
ناخد سؤال
فلوس.
تاني.
اتمنى ما يكونش حد اشعه قاعد معانا بس يا بيه.
لا، ما انا
طيب
بقول له في وشهم وانا اضحك بقى هم ينصبوا عليا انا. بقى انا عارف الام ار اي ده بيتعمل بالجادولينيوم بصبغه
ايوه
الجادولينيوم.
ايوه
هم ما بيحطوش جادولينيوم. ما هي ما تنفعش برضه.
امال بيحطوا ايه يا بيه؟
بيحطوا حاجات زباله كده، تكنيشيوم ولا انا عارف، بيحطوا حاجه كلام فارغ
ايوه
كده.
ايوه ايوه فاهم.
او بيحطوا نطره جادولينيوم مثلا عشر الانبوله ولا حاجه يمكن، ولا حاجه زي كده. عشان لا، المهم ما
انما
بيعملوش
هو يعني
بالجادولينيوم.
يعني the use of
اللي
contrast.
بيعمل جادولينيوم بيكتب كده ويز جادولينيوم.
طب في
يعني
سؤال حلو، لو
موريال
مالتي
بيكتبوا
سنتريك.
ويز جادولينيوم،
ايوه
بيكتبوها. عمره
لو
هنا ما
تيومرز
كتبوا جادولينيوم.
لو
نعم.
تيومرز مالتي سنتريك بتحتاج تاخد بايوبسيز من كل التيومرز؟
بص الستاندرد
لازم.
nowadays is taking one biopsy from one tumor which is the largest. عادة بياخدوا النهارده من one single tumor اللي هي أكبر واحدة. إنما في recommendations أنا قدمتها في الأول إن هم ياخدوا separate biopsies from separate tumors. وده ليه؟ لأن أوقات لو هي مالتي فوكال عادة هتلاقيهم زي بعض ك بيولوجيكال بيهيفير، واللي هو الاميونوهيستوكيمستري والهرمون ريسبتورز وكده. انما يقال ان المالتي سنتريك ممكن ان هم يبقوا ديفرنت، وبناء عليه they encourage the taking of biopsy from separate tumors in separate quadrants. انما اللي
طب انا،
بيحصل النهارده ان هم بياخدوا من اكبر واحده and that's it one single tumor.
لا بس انا اقول لك حاجه في دي بقى.
ايوه
انا سالت بنت اختي، هي براكسسنج راديو دايجنوزس في شيكاغو.
ايوه
انا سالتها السؤال ده.
ايوه
قالت شوف احنا هنا هي المشكله في الكالسيفيكيشن، فاين irregular كالسيفيكيشن.
ايوه
قالت ان عشان انت دلوقتي ما تقدرش تقول مالتي فوكال وتاخد بايوبسي من الكبيره وتسيب الصغيره. فلما بيكون في suspicious مايكرو كالسيفيكيشن اللي هي فاين irregular مش عارف ايه، بناخد بالستيريوتاكتيك بايوبسي حتى لو وان سبيك اوف كالسيفيكيشن بناخدها تطلع.
اه
فقالت لازم كل اللي suspicious areas في البريست تاخد منها بايوبسيس، بالذات هي الكالسيفيكيشن
يعني لو
بالستيريوتاكتيك.
يعني لو عيانه عندها 5 6 تيومرز.
اه قالت لازم، لا ما هو لو انت 5 6 يوم هتعمل ماستكتومي مش هتعمل. قال لي لازم لو كان 2 3 بتاخد، لان ممكن التانية تطلع بناين.
ايوه
ما انا اختي عملت لها العمليه بتاعت بريست كانسر، كان
ايوه
في 2 ليجنز، عملت اللي انت بتقوله كده،
ايوه
شلت الاثنين. واحده منهم طلعت فايبر ادينوما حوالي نص سنتي
اه
بعد ما
اه
شلت
اه
جزء كبير من البريست الصراحه يعني.
اه
فدي
هي
غلطه انا عملتها.
هي طبعا لو كانوا خدوا
عايشه
بايوبسي
دلوقتي بقى لها
منها.
15 سنه،
ايوه
لكن الليجن الثاني طلع فايبر ادينوما.
ايوه ايوه
وانا استعملته كانه كانسر.
كلام حضرتك مظبوط، لو كانوا خدوا منها بايوبسي كنا
كان
تفادينا
وفر
تفادينا لارج
العمليه دي.
لارج لامبكتومي في البريست.
هو
هو
طيب
الريكومنديشن حاليا.
ناخد سؤال تاني.
ايوه
دكتور ابراهيم سلام.
مساء الخير يا باشا دكتور شريف.
اهلا دكتور ابراهيم، ازيك يا حبيبي؟
I would like to thank you for the wonderful presentation first of all.
Thank you دكتور ابراهيم.
And thank you Dr. Medhat for highlighting all these points. So my first question was about diagnosis, and you already answered that about the MRI, the role of the MRI in diagnosing multicentric and multifocal. My question to you is, do you personally adopt which technique, mastectomy or conservation for multifocal cancers first?
لا المالتي فوكال تقريبا اتحلت من زمان. if you can remove all the tumors together in through one incision in one block of tissue, assuring negative margins in all directions and achieving an adequate cosmetic result, then you have done what is required. يعني كل التيومرز in one block مع negative margins مع good cosmetic result انت عملت اللازم. You don't need to do mastectomy for multifocal. هي المشكلة كلها في المالتي سنتريك. المالتي سنتريك ان احنا النهارده بنتكلم على separate incisions و separate lumpectomies او multiple lumpectomies. هو ده اللي احنا بنتكلم فيه. هو ده اللي لسه محتاج randomized control trial عشان نقدر نعملها واحنا يعني متشجعين. انما لو انا جات لي هشوف لو قدرت اعمل multiple lumpectomies واحط في كل تيومر باد كليبسات علشان كل تيومر باد من دول ياخد adjuvant booster دوز اوف راديوثيرابي وبدون ان تتخطى الجرعه اللي هتتاخد على البريست 60 جريز في 40% اوف ذا تيشوز، هعمل مالتيبل لامبكتومي. انما لحد النهارده المالتي سنتريك انا بعمل له ماستكتومي، والمالتي فوكال انا بعمل له بريست كونزرفيشن لو قدرت مع انكوبلاستيك ريكونستراكشن.
Okay, so for the multicentric, if they are like two small cancers and both are distant in a larger breast, will you prefer conservation for this patient or not?
والله لو two small tumors وبعاد عن بعض I would think of double lumpectomy. two small tumors وبعاد عن بعض. انما ما شفتهاش لحد النهارده، فالحمد لله ما اتحطيتش في هذا الموقف يعني.
Okay, and I wanted to mention something about the multicentricity and the multifocality. So when Dr. Medhat asked about do you add the risk of having multicentric cancers, is it double the risk of single cancer? So the thing is, when you have multiple tumors, for example, when we are conducting the oncotype testing for all the tumors, not every tumor is the same. So every tumor is behaving different. So it's about the different tumors behaviors, even in grade 1 or 2. If all of them are the same grade, with or without lymph node involvement, doesn't matter. It's all about like each tumor behavior. And you mentioned in the presentation that in the single tumor, if we are taking like the multifocal cancer, every tumor separately counts as the same risk as a single tumor, but having like multiple cancers, it's a big load of cancer in the breast, so we don't know what the behavior in the future. That's the point that you highlighted about future areas of exploration and research.
This is true, Dr. Ibrahim. As I was telling you, they are criticizing the TNM staging that we are using today, because when you have multiple tumors, you assign a T stage that is based on the size of the largest tumor present. They found that lymph node involvement with these multiple tumors is more related to the sum of the sizes when you compare it to unifocal. So they are thinking of changing the TNM staging because of that. So the risk of metastasis and the prognosis is probably related to the sum of the sizes when there are multiple tumors more accurately than if you take the actual TNM اللي هو ال T stage related to the largest tumor فقط.
Okay. And my last question to you, sorry about that. If you're having a lady with a small to medium-sized breast, having a multifocal cancer, surrounded by DCIS, and she's asking for conservation.
Surrounded by DCIS, يعني all over the breast.
So we're talking about like a 5 centimeter in a small or moderate sized breast. What do you personally recommend in this situation? So
I think that all diseased tissue should be excised. And I was telling you, as I was telling you, if you can remove all the disease in the breast through one incision, in one block, and assure negative margins and a good cosmetic appearance at the end, then you have done what you are required to do. So if you find that removing all these tumors together in one block will remove more than 50% of the breast, وهو, as you were saying, it's a small or moderate sized breast, I think mastectomy is definitely much easier. So I would do mastectomy. A nipple sparing or skin sparing mastectomy. ودلوقتي النيبل سبارنج والسكين سبارنج مع ريكونستراكشن الحقيقه اصبحت سهله ونتائجها حلوه جدا.
Yeah, of course. Yeah, exactly. I totally agree on that. And the last point I would like to add about the biopsies in the beginning at the time of diagnosis. So when it's according to the recommendations of the Royal College of Radiologists, they are obliged to biopsy every suspicious lesion in the breast with the ultrasound in the first instance. And after that, when we request an MRI for the patient, if it spot any lesions, any new lesions, if they are carrying the same criteria as radiologically as old lesions, so there is no point to biopsy any more tissue from the breast.
I don't really agree, because you don't only want to know if this lesion is malignant or not, زي الحالة اللي كان بيقول عليها الدكتور مدحت بيه من شوية اللي طلعت فايبرو ادينوما ولو انه ما كانتش بايوبسيد فاضطر يشيلها اون بلوك مع الكانسر. This is not the only aim. There is also another aim, which is to know the biological behavior of the tumor. Because one tumor could be, for example, luminal, and the tumor close to it could be triple negative. And you will need to give chemotherapy in this patient. You will not give hormonal treatment. So to my mind, taking biopsies from all the tumors separately is definitely an advancement and definitely required. I know it's more expensive, but it could change the life of many patients.
It's usually according to the situation. If the other cancer is within the matter of the same tumor, I mean, very close to it, and like showing the same radiological criteria as the one that has been biopsied, that's fine. But if in a different location or in the other process, totally agree. I have to be biopsied as well.
ده كلام مظبوط يا دكتور ابراهيم. they found that multifocal tumors are usually very similar histologically and biologically, and multicentric tumors are frequently different histologically and biologically اللي هو الهرمون ريسبتورز وكده.
Thank you very much, Dr. Sherif. Can I say one more thing, one last thing before I go? It's to Dr. Hisham. If you're having such like a brilliant group, and Dr. Medhat Khafaga today highlighted the importance of conducting like a new randomized controlled trial, why don't you initiate that and discuss with your colleagues and like raise that issue in the group and think about any kind of trial, and all the Egyptians can lead on such trial?
We'll see about that.
Thank you.
الدكتور مدحت يعمل لنا بقى الترايل دي.
لا ده انتوا ما بتسمعوش الكلام في اسم البريست. لا
في سؤال تاني دكتور عمرو غانم.
اتفضل يا بيه.
ازيك دكتور شريف.
اهلا يا فندم.
بحيي الجميع طبعا. It was an excellent presentation. انا بس حضرتك الرسمه اللي حضرتك حطيتها بتاعت العمليه is it different from the bat wing mammoplasty?
Let me go back.
It looks the same, like when you have two wings and you just excise it the same way and suture it after that. Is it the same one?
لا، هي اصل البات وينج is horizontal transverse excision.
All right.
With the two wings mainly aiming at adjusting the skin triangles for a cosmetic closure.
تمام.
انما
هنا اللي حضرتك حاططها كانت two tumors or whatever, it's multicentric in the upper outer and the upper inner quadrant, which is almost the same. That's what I'm talking about here.
يعني هي it resembles the bat wing, انما it has a different anatomical basis.
Yes, sir.
They are talking of
and it doesn't have to be horizontal.
Radial lobar anatomy ورadial lobar excision.
تمام.
mainly based radially في اللي هم الراديوس بتاع البريست.
ايوه.
البات وينج mainly horizontal.
mainly horizontal. yes sir. yes sir. هو ده بان. بس هضيف حاجه تانية برضو بالنسبه اللي حضرتك كنت بتقوله، انه احنا كان عندنا في السنتر، عندنا في بارتس في لندن، عملنا التجربه حضرتك قلتها، وعملنا separate incisions for or separate wide local excisions for multicentric diseases. Up to 3 lesions also as well. We tried that with very good success with radiotherapy after that. It was really successful. بس طبعا زي ما حضرتك ابتديت كلامك انه لسه ما فيش حاجه proven على اللونج ران ما ظهرت، بس يعني في اخر 3-4 سنين عملنا حالات كتير جدا من ديت يعني. انا ممكن اجمع الداتا دي لحضرتك لو حضرتك عايز يعني.
it is very interesting. وعايز اقول لك ان انا شفتها في ميونخ سنه 2020.
ايوه. حتى يعني في حاجات كنا اكتشفناها مش palpable tumors and the biopsies were MRI guided وعملناها بلوكالايزرز حتى كمان عشان نجيبها يعني.
many centers in the world do it now. They do
yes sir. Yes sir.
بس هي المشكله كلها في الراديشن. انا رايي ان دي لازم تبقى بلاند مع الراديو ثيرابيست بيفور هاند.
بري اوبتيف بالظبط.
واللي مهم جدا ان كل تيومر باد لازم يبقى ماركت وذ كليبس عشان البوستر دوز.
exactly. وبرضه بالنسبه للبيوبسيز اللي كان ابراهيم دلوقتي بيتكلم عليها، whatever the size of the extension, I think if you need to biopsy, at least the most important to biopsy the edges, the total extent, even if there is 6 tumors, whatever. أهم حاجة تروح على the most distant on each side. I think so.
I don't have any answer to that. I don't know. I don't know. But what I know is that that it is definitely better to biopsy all tumors separately، وبالذات إذا كانوا multicentric والديستنس ما بينهم أكتر من 4 سم أو 5 سم.
And this means also that tumor biology might change your plan of surgery also as well. In case if it comes like triple negative, one of them triple negative or HER2 positive, you will do for a readjuvant first, yeah?
Of course.
Yeah, sure. Okay. شكرا بيه. شكرا جزيلا.
شكرا دكتور عمرو.
Do you have any other questions دكتور جمال أميرة؟
انت خدامة.
الو.
Yes دكتور جمال اتفضل.
ازيك يا شريف بيه؟ excellent as usual يعني.
حبيبي يا دكتور جمال.
دفعتي وصديقي.
حبيبي يا دكتور جمال.
طبعا excellent presentation بس I have some questions.
اتفضل يا بيه.
If you have 3 tumors in separate quadrants, I think it is very difficult to do resection for 3 lumps. This is a sort of disseminated disease, or what you think? 3 tumors in 3 different places.
هو disseminated انما is the tissue in between them normal or not? This is the most important point. If the tissue between them is normal, some people suggested multiple lumpectomies. ولكن زي ما قلت لحضرتك فيها شروط مهمة جدا تتوافر، وهي ان انت كل لامبكتومي لازم تعلمها بكليبس، ولازم تاخد بوستر دوز اوف راديشن. والبوستر دوز اوف راديشن ده لما يتجمع على بعضه لازم ما يعديش 60 جريز to 40% of the breast tissue، والا البريست هيتحرق. وبناء
طب
عليه هي مشكله راديو ثيرابي اكتر من اي حاجه تانية، بلس كوزميسيس.
تمام. if you have 3 lesions زي ما قلنا 3 different quadrants and their size collectively 7 centimeter, do you give neoadjuvant therapy or no?
their size completely كام؟
7 سنتي مثلا، 7 في 4 او 7 في كذا، مجموعهم دول تديها نيو ادجفنت ولا لا؟
هديها نيو ادجفنت بيزد اون ذا سايز؟ لا، مش هديها نيو ادجفنت تريتمنت بيزد اون ذا سايز، لسبب ان هم 7 سنتي ده ما هواش الحجم اللي هيكش. اللي هيكش هو ال 2 سنتي بتاع دي، وال 2 سنتي بتاع دي، والسنتي بتاع الثالثه، و they will shrink in size but they will remain at their same position. They will not approach to each other. The distance between them will not be less. وبناء عليه it will not change the surgical plan. I will still have to remove a large part of the breast if I want to do a large lumpectomy or a segmental mastectomy. يعني النيو ادجفنت مش هيقرب التيومرز على بعضيها.
لا مش كده.
السيرجيكال بلان مش هيتغير.
لا النيو ادجفنت هيخلي اللي 3 سنتي وال 2 سنتي نص سنتي او اقل. هل ات ذات تايم اكون انا حاطط كليبس في كل واحده فيهم وادخل اشيل از سمول از بالنيو سايز؟ هل هعمل كده؟
يعني ممكن اعمل كده في حاله واحده لو كان البريست صغير، والمالتيبل لامبكتوميز اللي هي المفروض الهدف منها الحفاظ على اكبر قدر من البريست تيشو. لو البريست حجمه صغير لدرجه ان انا اشيل 3 سم من هنا و3 سم من هنا ممكن يبوظ شكل البريست، ممكن افكر اديها نيو ادجفنت عشان اصغرهم وينزلوا لسنتي واحد، وساعتها ممكن اعمل مالتيبل لامبكتوميز من غير ما اشيل حته كبيره من البريست، سنتي من هنا وسنتي من هنا وسنتي من هنا، ويبقى البريست لسه فيه بريست تيشو يكفي يعني.
طب هل في موديفيكيشن فور اكسيلاري ديسكشن اكوردنج للحاجات دي ولا هو ذا سيم؟ يعني هل مثلا هستعمل سنتينل نود، ولا هل مع النيو ادجفنت هكون حاطط كليبس في السسبيشس نود وهعمل سنتينل؟ يعني
ده موضوع تاني بقى.
هاو تو مانج ذا اكزيلا في الحاله اللي فيها مالتيبل تيومرز in 3 quadrants او حاجه كده.
You use the same technique as a unifocal tumor because the sentinel lymph node is the sentinel of the breast. It is not the sentinel of the area where the tumor is. يعني the whole breast has this one and the same sentinel lymph node. فكونها يونيفوكال او مالتي فوكال او مالتي سنتريك في الابر اوتر كوادرنت في اللور انر كوادرنت، في الاثنين مع بعض مش هيفرق، هي سنتينال ليمف نود واحده بتاعه البريست كله.
You can use one incision for the 3 quadrants وتخش من داخل البريست تيشو سونار جايدد انك تشيل التيومرز الثانيه ولا لا؟
والله ممكن لو if it is accessible why not. ما هي مشكله المالتيبل لامبكتوميز ان انت مش هتعرف او الشكل لو عملت مالتيبل انسيجنز مش هيبقى مقبول، فلو قدرت ان انت تعملها من وان سنجل انسيجن اكيد يبقى شكلها احسن.
شكرا جدا شريف.
اشكرك يا دكتور جمال
حبيبي.
دكتور ابراهيم عنده سؤال تاني؟
اتفضل يا بيه.
It's not a question. I just
ده اخر سؤال بقى عشان
okay, just very quickly. When planning for multifocal cancer or multicentric whatever, Dr. Gamal was talking about 3 tumors. So Dr. Sherif, do you use double flaps or a flap with lipofilling? What's your technique these days?
To reconstruct what type of defect?
For example, if you are removing like 2 distant cancers.
I think a therapeutic mammoplasty.
If medium size, I'm talking about medium size breast, which is the challenging one. and you are removing like multiple areas of the breast. So what's the best? Is it like double flap or one flap with lipofilling, or just flaps, or you postpone the filling and the flaps for a second session? What's your intervention?
والله يا دكتور ابراهيم انا شخصيا I've seen very bad results with lipofilling, so I'm not really a very big fan of lipofilling. I have seen fat necrosis that was mistaken for recurrence, and the patient at the end had to go for mastectomy, and it was only fat necrosis after lipofilling. So I'm not really a big fan of lipofilling. Actually, if it's a medium-sized breast and the defect is large, I would do one flap. And you can also combine your flap with breast tissue displacement. يعني you use one single flap and you use breast tissue displacement to cover the other defect. So one flap is usually enough. You don't need to do two flaps.
Like doing a stacking procedure, like moving the original breast tissue and filling.
Moving the original breast tissue, we're adding the two defects together and filling the two defects with only one flap.
Yeah. And my last question to you, do you use frozen sections always in your cases?
Yes.
الحقيقة we are lucky and we are spoiled to have a frozen section in all our cases. And this I know is not available for surgeons in the UK. دكتور إبراهيم يقدر يقول لنا ولا in the United States. The very 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 rare centers have frozen section. احنا الحقيقة we are blessed and we are spoiled and we are lucky to have frozen section.
You simply spoil your patients.
And spoil the surgeon mainly.
Yeah.
So we have a far smaller number of re-operations and the far smaller number of mastectomies in small tumors.
Yeah, and it's usually challenging if you have a positive margin, like in a patient with reconstruction or with flap or with a simple like lumpectomy.
You end up with a mastectomy.
Yeah.
Sometimes.
Yeah. And it's usually
one more question, Dr. Ibrahim Zayat.
Wow. Yeah.
السلام عليكم.
وعليكم السلام وبركاته.
دكتور شريف بيه كالعادة يعني حضرتك يعني محاضرة شيقة للغاية والجميع مستمتع بيها. متشكرين لحضرتك جدا.
يا دكتور إبراهيم الله يخليك.
يعني هرجع بس لحضرتك كنت بتذكروا ان في اللوبولار ديزيز from embryology starting from embryology.
أيوة.
Is there any research work to stop this precancerous changes before it change to cancer? So from the embryological event.
اللي هو الجيناتيك ميوتيشن اللي بيحصل في الامبريو.
Yes.
الحقيقه I didn't hear about it، بس يعني بيتهيألي ان ده مش تخصصنا او مش تخصصي، مش عارف. هي طبعا تبقى فكره جميله جدا يعني. وده مش هيبقى في البريست بس، ده هيبقى في كل الكانسرز، ان هم يعرفوا الجين ميوتيشن اللي بيحصل ايه وبيحصل فين ويحاولوا هم يصلحوه. يا ريت
يعني يصلحوه، يعملوا له جين ديليشن زي ما كانوا بيقولوا زمان، ان احنا ممكن ندخل كده.
ده يبقى بريك ثرو يعني. يا ريت طبعا.
اوكي، شكرا يا فندم.
اشكرك دكتور ابراهيم.
اوكي خلاص هنضطر ننهي بقى عشان التايم. شكرا. ثانك يو اول
شكرا
فور
دكتور هشام.
اتندنج.
اشكرك دكتور هشام.
ونتمنى دكتور شريف ده تدينا محاضرة تانية قريب ان شاء الله.
ابقى سعيد يا دكتور هشام طبعا.
اوكي شكرا. ثانك يو. تصبحوا على خير يا جماعة.
على خير.
Good night everyone.